everyone, and welcome to today's webinar. This is Rick Import for Orchard Software, and our session today is Laboratory Data Sharing and Interoperability, Responding to a Pandemic. And our presenters today are Kim Futrell, Senior Strategic Marketing Manager with Orchard Software, and Matt Modleski, Executive Vice President for Business Development, also with Orchard Software. And our session is sponsored by our good friends at Orchard. Kim Futrell is the Senior Strategic Marketing Manager at Orchard Software. Kim has a bachelor's degree in biology, is an ASCP certified medical technologist, and has a master's of science in health informatics. After more than 20 years as a laboratory manager, Kim worked as operations manager for a multi-specialty physicians group, helping them merge with a local hospital prior to transitioning to Orchard Software in 2012. With Orchard Software, Kim is a contributing author for numerous laboratory-related magazines and Orchard's White Papers series intended to educate and inform laboratorians of current, relevant industry topics and promote the value and importance of the laboratory. As Executive Vice President of Corporate and Business Development at Orchard Software, Matt Modleski is responsible for strengthening Orchard's corporate relationships and bringing additional value through new business opportunities. Previously, Matt led the operation of more than 70 physician practices and was a key member of the executive team at American Health Network. From 2006 to 2014, he was a partner at Stovall Granger Modleski, a healthcare consulting firm with expertise in the healthcare environment and competitive positioning. Prior to his work in healthcare sales and marketing, Matt was an accomplished pilot in the U.S. Air Force. He was awarded the 355th Wing Instructor Pilot of the Year and was also a solo pilot on the United States Air Force Air Demonstration Team, the Thunderbirds. Very impressive, and you will really enjoy hearing from both of our presenters today. So Matt Modleski will be leading us off, and I'll turn it over to you. Matt, welcome.
Well, thank you very much, Rick. Listen, I realize it's 1:05 for those of you on the East Coast, so we're battling postprandial narcolepsy. So our job is to keep you awake for the next 50 minutes or so. So we'll do our very best, Kim and I, at making that happen. Laboratory Data Sharing and Interoperability Addressing a Pandemic. It's a title that you probably won't hear often, and we certainly feel like the learning objectives are different than most other webinars you'll find as well. So hope you enjoy. Here we go. The learning objectives for today, we want to review the successful components of South Korea's COVID-19 response and identify differences in the U.S. response. We'll also call out sort of the apples and oranges of looking at South Korea versus the U.S., but there are some things to learn, and we'll certainly identify some of those as takeaways. We want to understand the role of interoperable systems to both a pandemic response and the value to healthcare overall. We want to define some current barriers to interoperability adoption in the U.S., and actually there is some light through that tunnel in certain spots. We'll talk about that. Evaluate the lessons learned from South Korea's pandemic response that can be applied in the U.S., and finally recognize the laboratory's role in data sharing as it relates to pandemic response and to overall healthcare interoperability. So that's hopefully what you'll walk away with. Let's talk about South Korea's COVID-19 success story. If I could work these arrows. Rick goes through all this practice with us. Press this button, make this work, and then my third button I miss. One of the first countries to be affected by COVID-19 was South Korea. In January of 2020, January 20th, they had their first confirmed case. It was at the airport. A month later, they had a cluster of transmission amongst the religious group linked to the 31st case in the country. And then from there, they really rapidly expanded testing to not just contacts, but suspected cases based on physician judgment. And by February 29th, their case incidence had peaked. The citizens were asked to stay home for at least 2 weeks at that point. And I think when we look at the numbers, all of these actions, and especially when we talk about the testing, you'll see led to what by all measures was a really successful story. So what did they do so well in South Korea? If you look at the graph overall, the top line, the green line is the U.S. and the bottom line is South Korea. Clearly the bumps are similar. It's just that the magnitude of the bumps were greatly minimized in the South Korean response. So there was great interest, and still is great interest, in sort of the test, trace, isolate strategy that South Korea executed. And their initial spike in COVID-19 cases, were met really with a rapid expansion of testing, and they had better outcomes with less stringent social measures and distancing measures than both the UK and the US. So let's move to the next one and see why that happened. So what did they have in place that enabled that sort of response? These are kind of the key strategic elements and the infrastructure that was in place in South Korea. So they had the ability and expanded the ability to identify clusters and contact tracing. They did a good job at isolating cases and self-quarantine of contacts. They had strong social distancing measures in heavily affected regions. They rapidly expanded testing capacity. They had national infectious disease plans, and they had an adaptive healthcare system with really government-driven communication. So those are kind of the elements of what they had in place, and then here's kind of how they used it. Detection, containment, and treatment. So South Korea focused on high-capacity screening facilities, and they worked closely with the private sector to ensure adequate supply of tests. They isolated infected patients very quickly, and they increased compliance by supporting the people that were in quarantine, which was really important. And they thoroughly traced contacts. And in order to do that, they integrated different sets of data. And when we talk about interoperability and data integration, you'll see the types of information that they put together in order to have this effective contact tracing. And then they treated, they restructured their hospital systems. They built temporary hospitals to increase capacity. They also used their interoperability and data to address PPE shortages with centralized government purchasing. So these sort of three elements would be kind of the keys to their success. Important to note, and I said we talk about the apples and oranges of South Korea versus the U.S. These are the three types of data that really were critical to their tracking and contact tracing methods. So medical records, credit card data, and even GPS data. And there's a reality for people to allow that sort of data to be used and integrated. There needs to be some level of trust. So we thought these two numbers were pretty stark, and we're not trying to send you for a Google search to see if we're telling you the truth. You'll find a wide variety of measures of trust in sort of federal government in the U.S. or the central government in South Korea, but these numbers are fairly far apart. 84% of South Koreans accept the loss of privacy as a necessary trade-off for public health security. And only 17% of Americans today say they can trust the government to do what is right. And so, like I said, I'm not sending you to Google to see if you can find a different number. The point to be made was, in order to integrate data, and this is a barrier to interoperability in the U.S. in general, which we'll talk more about later, there has to be some central level of trust to what's going to be done with that data. And so we thought it was important to point out this sort of first major difference between the two nations. When it comes to testing, though, these numbers are stunningly good. South Korea licensed private companies and clinics to conduct tests very early in the pandemic. So on February 7th, they were testing 3,000 people a day. By the end of March, they were up to 20,000 people a day. By the end of March, they had performed more than 300,000 tests, which was 40 times higher per capita than the U.S. at that time. And if you think about how important early testing is to get your arms around a pandemic, this is one of their very key success stories. The turnaround time was in the 6 to 24-hour range. It's also important in this slide to talk about the second major difference between South Korea and the U.S., and that is geography size, right? So South Korea has 51.7 million people in a geography essentially the size of Indiana. And so the ability to test those people quickly in a concentrated geography was obviously easier than spreading 300 million people out across our country, 330 million. But the speed to testing, both from a capacity and facility perspective, as well as that tight geography, led to a very successful testing campaign, and that obviously was used to manage the pandemic. So South Korea wasn't always quite so prepared, and part of the reason they were so ready to act in 2020 was linked to their 2015 response to MERS. And so the MERS fatality rate, based on 186 laboratory confirmed tests, was about 20%. So they had 38 deaths. There were many more suspected cases than the 186 confirmed, but nevertheless, the MERS outbreak in 2015 really got their attention. And so the changes made at that point were the government expanded legal and administrative boundaries for pandemic responses in general. They boosted infrastructure, enhanced processes, they enhanced legal powers for quarantine, surveillance systems, and enhanced their digital technology. So, 5 years earlier, as they, felt like their response to MERS could have been better, they took those lessons learned and put them to use, leading to these changes. 48 reforms to boost public health emergency preparedness and response. They had a well-functioning national health insurance system. They had ample human resources applied to that infrastructure that they had put in place, and then very constructive relationships between their key, what we would call federal institutions in the President's office, their ministries of health, education, and foreign affairs, and the Korean Centers for Disease Control and Prevention, which has been renamed Korea Disease Control and Prevention Agency during the pandemic. So again, MERS happened. They weren't happy with their response. They made changes to their government agencies and sort of the legal lines that could be drawn in another pandemic. They estimated they lost about $2.6 billion in tourism revenue during that MERS outbreak. So there was another reason, right, that they needed to be better. They needed to keep their economy up and running as well. So lots of lessons learned from MERS. They, were applied very well in the COVID-19 pandemic. So some of the data changes that came out of the MERS outbreak, they allowed access to these 4 types of information in addition to patient and doctor interviews. They could access facility visit records, cellular GPS data, credit card transaction logs, and closed circuit television. So again, if you go back a few slides and think, how would this float in America? Probably not nearly as well as it did in South Korea, but this information was key for them to be able to move so quickly in isolating and quarantining people who tested positive. They also scaled up their network of contact tracers. Workers were given access to data beyond the typical patient interview, which I just mentioned. And there was a public communications effort to empower citizens to assist with contact tracing. If you say contact tracing 12 times really fast and don't mess it up at all, send me a chat to say how you did it, because I struggle when I have to say that fast. All right. In response to COVID-19, okay, so now we've taken lessons learned in MERS, made changes to things that we can do. In June of 2020, the South Korean government added a system called KIP Pass to help contact tracing efforts at high-risk locations. So these are like QR codes for places like bars and gyms instead of a manual sign-in sheet. So think about how effective that would be to have a scanned contact into a database that you could then use to, contact trace people. So very effective. Even with that reality, you can see in the blue here, to respond to public concern about data use and privacy, the government instituted additional data protections, including automatically deleting data after 14 days. So you know, everybody has privacy concerns. This is the way that they address those things, which was very helpful, very effective. Mandatory mask wearing was another key element that South Korea implemented in October of 2020. They put a little bit of weight behind that effort and fined people what would be the equivalent of $90 if they weren't wearing it. So data-driven agility. Clearly, if you look at the response here, less than 80,000 cases and 1,500 deaths a full year after the first case reported. The keys to that level of success were really clear, effective communication with the public about prevention, aggressive testing, and contact tracing. That, to me, is really the thing that stands out is how fast they ramped up testing and how aggressively they used technology to help contact trace and isolate people. And then they obviously quarantined. They had a quarantine policy backed up by support for those in quarantine that made it easier for patients to comply. Culturally and legally, South Korea is more tolerant of personal data sharing. I think I got a slide here by a researcher in Colorado, Jung-Jun Yu, who says, their extensive surveillance and contact tracing using information and communications technology may not be applicable at the federal level in the U.S. due to different cultural norms. I would take that back to the trust slide. I think culturally we could get here. Certainly after this pandemic, there are some folks who would be very willing to share information. I do think that we would need some reassurances into that data being deleted, et cetera. But there is a bit of an apples and oranges comparison here, but there certainly are key lessons learned. And the biggest ones, I think, are speed to test and contact trace really matters. Speeding up testing and contact tracing really matters. It was proven here beyond any doubt. The cultural realities we've talked about. And then interoperable data sets impact tracing effectiveness. So the ability to integrate, bring data from one source and another into a central view really did matter here. And that's kind of the subject that we want to move to next, the value of interoperability, both to the U.S. healthcare system and pandemic response. So let's break that down a little bit. So healthcare interoperability, what does that mean? Well, it really is the enablement of communication and exchange of data between different information technology systems to allow providers, healthcare providers, access to all the data for a patient being treated. And it sounds easy, but it's not. There's sort of two elements to this. There's the stuff that you're used to talking about, like structural interoperability, HL7 interfaces, transmission of patient data from connected devices. You know, those are the things we normally think about when we talk about interoperability. And then there's semantic interoperability, something like a healthcare information exchange, which people go, what's that mean? Or data collection methods for population health. Again, if I asked you all to write down the word population health and write 5 things it means to you, we would not agree on all 5 across the audience. So, but there is some basic acceptance that in order to manage population health, we're going to have a more interoperable system. So, collecting data for COVID-19, obviously, if we improve coronavirus surveillance efforts, we can isolate sick people quicker. We have to be able to monitor the spread of the virus and its impact on the healthcare system overall, which would include identifying hospital supply needs and bed capacity. We need approaches for case identification, containment, and resource allocation. And this last statement, I think, is really important. Even de-identified data can be very meaningful. Think about the ability to look at a state like Indiana or any other. I'm just sitting in Indiana, so it's top of mind. And looking at real-time reporting of positive tests. If I was looking at that at a county level, I could very quickly identify, without knowing any of the patient information, just a positive or a negative test. I could look at those clusters and then begin to deploy resources. So when we talk about an interoperable system, and we'll talk about the barriers to it, and I don't want anybody to start having their shoulders roll forward and feeling sad. The reality is there's a lot we can do, even with you know, the level of trust that we have today, in terms of using and integrating and making more interoperable de-identified data, which I think we could move more quickly towards. So what would it look like if we had an interoperable system? Well, a patient would go to a provider, and the provider would have access to their full medical record to address any underlying conditions. That would alleviate wasted time. It certainly would reduce or eliminate duplicate testing in our world. And shared data would improve the provider's ability to provide prompt and effective patient care. So think about it. A patient goes to primary care, they go to emergency care, they need, you know, quick decisions between the two, and it's very rare, unless that patient happens to be in the same, you know, system, that the doc at the ambulatory and acute setting has access to the same information. So we have to improve this. It is getting better, by the way. Many of you probably work in an integrated health system that does share data for the benefit of the patient, which is really good. So what are the barriers? If it's such a great idea, by the way, who doesn't think it's a great idea? I think it's a great idea to have a more interoperable system. But if it's such a great idea, well, why don't we already have it? Like this is, you know, 2021 after all. Well, here are some reasons. We'll talk about some of them directly. Data silos, resistance to change. Do you know anybody that's resistant to change? You ever wake up in the morning and go, you know what, I hope when I get to work today, everything is different. I hope my workflow in the lab is different. I hope I have a new boss. I hope everything about my job is different. No, nobody does that. So we have this, you know, natural resistance to change, and if you multiply that by millions, it's you could see why, you know, sharing data and interoperability will have some friction. We have inconsistent guidelines. We have missing or conflicting incentives, and incentives not tied to revenue. As our friend here at Orchard, Kurt Johnson, says, always follow the money. It usually leads to why things are working or they're not working. Let's talk about this data silo issue, because it's a big one. So if you think of each of these silos, lab, acute care, ambulatory care, you're in a different emergency room than you are in terms of your primary care. You go to pharmacy and it's not part of any of these other silos, and you think, oh my gosh, why is this so hard? Well, every one of these silos has a set of data sitting in a database, typically, that may or may not have any natural connectivity to the silo next to it. And so we've got to figure out a combined reason that it's beneficial to integrate these silos. And quite honestly, there are reasons that each of them don't want to integrate. And one of the main reasons is it's possible to monetize the data in your silo without sharing it. And so we have to be cognizant of that, careful of that, and realize that it is a barrier to sharing. And then there's this. It's 2021, and we're still faxing things in healthcare. Like, how crazy is that? You wake up in the morning and you think, you know what? I'm gonna go fax something to somebody. Like only in healthcare, in U.S. healthcare, would that be happening. So because we still do things this way, we still have crazy sets of guidelines that every state can ask for different things from a wide variety of providers or people providing data. The statistics are inconsistent. The data required is inconsistent. So we've got to get out of the faxing world in healthcare. Like, please, somebody save us from ourselves. It's the only place I can think of that in 2021 still has faxing as a primary method of sharing information. So I'll say no more about that, but it should make you crazy. We do have systems in place, though, that we've spent money on. The U.S. healthcare system has spent billions of dollars to incorporate the use of EHRs through the Meaningful Use program. That is now called Promoting Interoperability. EHRs are commonplace. They're just about everywhere now, and we did sort of federally enhance the move to EHRs. But here's what you need to remember. EHRs are really bellies. They're not brains, right? Electronic health records were built to store information. They weren't really built to think. Now, I would say they've come leaps and bounds from their original days of storing information to having some ability to help you think. But the reality is there are tools that overlay these EHRs that do think and do know how to go get information and pull it together. So we're not as far away from an interoperable system as you might think. EHRs are part of the solution in terms of storing information. But remember, if you're talking EHRs, you're talking bellies, not brains most of the time. So some systems exist, but simply aren't properly incentivized. So if you do any sort of reimbursement work, you know that healthcare reimbursement remains very fragmented. The Promoting Interoperability program relies on provider grants and incentives. Usually, many of them are driven by the federal government with Medicare or Medicaid initiatives. The private payers then tend to follow. I will say, having worked in a large med group, some of the commercial payers will do innovative things around sharing information. But overall, until we get alignment on the way people get paid, it's very hard to get people to share their data. So where it does happen, you know, there are a couple of places. Medical claims are transmitted electronically because that accelerates payments, and that's a good thing. Laboratories are generally well connected. In fact, I would say labs are one of the most integrated pieces of our healthcare ecosystem, and the reason is, as the order comes in, it needs to get to the lab. The results have to go back to the orderer, and people have figured out how to attach claims to get people paid relatively seamlessly. So laboratory is actually in a good place to be a thought leader around interoperability. And when I get ready to turn this over to Kim in just a second, she'll talk more about that. So all is not lost, right? We are getting better. You know, we're different than South Korea as it relates to a pandemic response for a variety of reasons, but there are some lessons that we can learn about the way that South Korea used data, about some of the ways we currently use data and could use it more effectively in our next pandemic response. In the meantime, though, there are things that we're doing today that I think, you know, you should leave feeling pretty good about. And what we're going to do is turn it over to Kim, and she'll drive this bus for the rest of the trip. And we'll both be ready to take questions at the end. Here you go, Kim.
So thanks, Matt. Great job. So we're going to shift gears just a little bit here, and we're going to talk about some of the things that we do have in place toward our interoperability goal. So as Matt said, labs are one of the most integrated pieces of our healthcare ecosystem. We have had LASs in place for a long time, several decades prior to the EHR, and they're a strong component of laboratory workflow. Most healthcare organizations also have an EHR or EMR, and those two systems are likely interfaced and sharing data. So this creates a fantastic foundation for interoperability within an individual healthcare organization. But the industry has made a lot less progress in connecting those systems and sharing data across different healthcare locations and between providers that are not within the same organization. So we have the technology, but data is still not being shared. And as Matt said, not properly incentivized, there's resistance to change, all those barriers that he alluded to. We also have terminology standards in place, and most of you are likely very familiar with your LOINC and your SNOMED CT codes. LOINC being logical observation identifiers, names, and codes, and SNOMED CT being your systematized nomenclature of medicine clinical terms. And not to get too deeply into LOINC and SNOMED, we could do a whole other webinar on those two terminology terms, But LOINC codes basically represent the question, or what test are we ordering, and then the SNOMED CT codes represent the answer when it's non-numerical, most often in microbiology and pathology. So if you look at the example in the image, in the place where the HL7 message has test results, you can see how a LOINC code identifies the question and the SNOMED CT code represents the answer. And so we need these standards because this is how two different information systems speak the same language and understand exactly what tests we're trying to order. So terminology standards are a key element of laboratory interoperability, and they reduce the time that we spend exchanging, tracking, and reporting tests. We also have SHIELD, which is the Systemic Harmonization and Interoperability Enhancement for Lab Data. You should try that 10 times. And this is a collaborative effort by the Medical Device Innovation Consortium. And so SHIELD believes that there should be one source of truth, that data standards should be approved by one sole authoritative source. And they also support the idea that manufacturers should provide LOINC and SNOMED CT codes to laboratories to help us consistently identify tests in our information systems. Specific to COVID-19, there's a similar alliance, the COVID-19 Interoperability Alliance. This is a collaborative effort between healthcare industry stakeholders that provides standards or value sets specific to COVID-19. These standards are intended to support data aggregation and interoperability so that we can greater understand the pandemic and then mitigate its spread. We also have ELR, or Electronic Laboratory Reporting, and this has been around for quite some time as well. And those laboratorians out there who perform testing for what we call reportable conditions are likely familiar with this. So reportable conditions are certain lab tests that we have to send to public health laboratories. And it's a very significant list of tests that includes everything from AIDS, hepatitis, foodborne pathogens, tuberculosis, rabies, many sexually transmitted diseases. Some of these tests have to be reported every 24 hours, and well, 24 hours after you get the result, and others within 7 days. So as part of the original Meaningful Use program back in 2015, I think, reporting tests electronically was one of the meaningful use objectives that you could use to meet meaningful use criteria and receive your reimbursement. We also have our Laboratory Response Network, which has been in place for more than 2 decades. This is basically our front line of laboratories that are lined up to protect us against a biohazardous threat. So it's a hierarchy of laboratories that will recognize a threat, either rule it out as nothing to worry about, or refer it up the chain through the LRN reference laboratories. So we have LRN Chemical, which detects chemical threats, and LRN Biological, which detects biological threats. This is similar to what South Korea has in place. This is the structure of the LRN, where we have sentinel labs down as the foundation. The sentinel labs are made up of more than 150 state and local public health labs, military, international, veterinary, agriculture, food, and water testing laboratories. So as I said, these are the front lines that would receive a test that could be a potential threat. Once they do, they send it to reference laboratories for confirmatory testing, who then send it to the national labs for definitive characterization. This is what it looks like, kind of the flow chart of the interface, where the potential threat comes into the sentinel laboratories. It goes through the LRN system, and it's reported to the CDC, the U.S. Army Medical Research Institute of Infectious Diseases, or the Naval Medical Research Center through an electronic portal called the Public Health Information Network Messaging System. So the LRN receives about 20 million reports every year, of which about 80% are through an HL7 interface. So even though we've had this in place for more than 20 years, participation in the ELR is still uneven, with the larger reference laboratories likely to be reporting electronically, but hospital labs, many of them are still actually faxing over that spreadsheet that Matt alluded to earlier. So some of the things that we have in place that we're trying to do to reach our interoperability goals in healthcare include the 21st Century Cures Act, which was signed into law in 2016. And this is a big chunk of money, $6.3 billion over 10 years, that goes to the National Institute of Health for a plethora of initiatives, including the precision medicine, Cancer Moonshot, the Brain Initiative, and the Regenerative Medicine Studies. And it also includes a big push toward interoperability. Its main goals are to achieve widespread interoperability among health IT systems and to improve patients' accessibility to their healthcare information. It intends to do this through specific measures that are governed by two different organizations, ONC-HIT, which is the Office of National Coordinator for Health Information Technology, and CMS, which is, of course, our Centers for Medicare and Medicaid Services. Specifically, ONC has interoperability rules for health information technology vendors that include the implementation of FHIR APIs. And I don't know if you've heard of this or not, but FHIR is Fast Healthcare Interoperability Resources, and APIs are application programming interfaces. So APIs are a different type of interface that are very open, scalable, and web-based. Plus, the ONC has information blocking rules. And if you're not familiar with the term information blocking, these are practices that prevent or discourage the exchange or use of electronic health information. And then CMS has its own interoperability rules that apply to health plans and hospitals around sharing of data with patients and health event alert notifications. As much as we could have used the interoperability aspect of the 21st Century Cures Act to mitigate the COVID-19 pandemic, the pandemic actually delayed its implementation for a second time, and so it is just now being enforced mid-2021 on into 2022. Specifically, for example, the ONC information blocking provisions just went into effect in April, and then in July of 2021, CMS is going to begin enforcing requirements for payers to implement APIs for patient access and provider directories, and then in December of next year, health information technology vendors who are ONC certified are going to be required to make APIs available to customers that meet specific standards. And then to follow up on the 21st Century Cures Act, there is a new federal health IT strategic plan that is a guideline as to how the government intends to use health information technology to promote health and wellness, overall population health, to enhance the delivery and experience of care, patient satisfaction, to help us build a secure system that accelerates research and innovation, and to connect healthcare with healthcare data. So they want to build a culture of secure access to our health information that can be exchanged and used by all stakeholders. And then specific to COVID-19, we have the CARES Act, or the Coronavirus Aid, Relief, and Economic Security Act. Again, a big chunk of money that goes into a lot of different areas, $2.2 trillion intended to stimulate our economy. This was signed into law in 2020, and it's for economic assistance to American families and small businesses. So this is where we get our stimulus checks, unemployment, payroll taxes, retirement funds, and then it also includes support for hospitals, for personal protective equipment, testing supplies, and vaccination costs. There's one portion of the CARES Act, Section 18115, that is specific to laboratories, and it requires laboratories to report the results of their COVID-19 testing every day to the Department of Health and Human Services or to your state and local public health department. And so these are the data elements that you're required to report. The 18 at the top go to the Department of Health and Human Services, and you can see that this includes your LOINC and your SNOMED CT codes. And then the 6 data elements at the bottom go to your local, state, or public health department. So obviously, if you look at this extensive list here, it would be much easier for this to be involved in an interface that's just sitting there with each field to click in each one of these data elements, rather than keeping track of a spreadsheet and faxing that over every single day for your COVID-19 results. There are also some market disruptors. There's a collaborative effort taking place between Google Health and Ascension being one of the largest healthcare organizations in the United States. And what they're trying to do here is they have a cross-platform EHR tool. It actually sits on top of the EHR. So as Matt said, the EHR is the belly, not the brain. So it's built to hold data, to store data, not necessarily built to pool and share data. The tools like Care Studio are built to pool and share data. So they sit on top of the EHR and they allow the provider a centralized view of information from different information systems, including hospital visits, outpatient information, lab tests, medications and treatments, and progress notes. So what an application like this does is it takes Google's expertise in organizing, pooling, sharing data, and it applies it to the healthcare market. So why do you care about all this? Why is this important to us as laboratory professionals? So an interoperable healthcare system is needed to advance our healthcare system, to move us toward value-based care, to prepare for future pandemics. When we don't have data interoperability and our data, our clinical and financial data sits in those silos that Matt showed us, it's caused us challenges for decades. So disparate data prevents providers from having that comprehensive view of the patient. All they get is what they can get out of that patient in that 15-minute visit and what they can glean from the EMR. So disparate data slows our shift to value-based care, to patient-centered care, and it diminishes our ability to respond to a pandemic like we saw South Korea do in their response. With an interoperable healthcare system, we can effectively communicate lab orders and results across care locations and between treating providers that aren't in the same location. Sharing patient data is really foundational for us to manage a public health crisis like COVID-19. So I'd like to stress the importance of laboratory professionals understanding and embracing interoperability, and then our healthcare system will begin to back it with regulatory measures and an incentive structure that encourages interoperability between vendors and healthcare organizations. So the key messages that Matt and I would like for you to take home from our webinar today is that interoperability and sharing patient data is widely recognized as part of the solution to improve patient outcomes, to move to value-based care, and the laboratory really is at the heart of it. The laboratory sits in the middle of this interoperability conundrum, so to speak, because they manage a tremendous amount of data and vital data that providers need to diagnose patients, to formulate treatment plans, and to make all the patient care decisions. And then lastly, because we're in the midst of this COVID-19 pandemic, it has become really obvious, and particularly with our South Korea example, how important it is to have data sharing during a pandemic or a public health crisis. So there's some solid steps, solid lessons that we can learn from our South Korea example and combine that with the systems that we already have in place, our LRN. We have systems, but we need to use them more broadly. So as interim steps, we can begin to strengthen those tools we have and use that de-identified data when it's available and beneficial. Some action items, some take-home lists for you. So just think about what we talked about today. Think about what interoperability means to you and within your organization. And where does your organization fit on that scale of interoperability? What has your laboratory started to do to work toward that goal? Have you implemented your low-income SNOMED CT codes within your interfaces? Have you standardized your test menus and your test names across your laboratories? Or do you still have 6 different ways to order a vitamin D and acronyms that all mean alkaline phosphatase? So these efforts toward interoperability also align with our laboratory stewardship goals, where our overarching goal is to provide the best service that we can to providers so that we can boost patient care. And so one final thought related to COVID is that testing is one of the most significant parameters necessary to track and mitigate a pandemic, and the public health management of a pandemic needs to be highly organized, which includes accurate lab testing, standardized test results, data sharing, and the capture of the demographic information that allows for the contact tracing, mitigation, and control of the virus, like we saw South Korea ramp up. So in closing, I'd just like to say thank you to everyone who has been diligently working at the front lines to address the COVID-19 pandemic. You are healthcare heroes. You sit right in the middle of the interoperability conundrum and can begin to take steps to improve sharing of our laboratory data. So with that, I thank you for your time, and I will turn this back over to Rick, and we'll get to the Q&A.
Well, thank you very much, Kim. You and Matt, as always, have done a fantastic presentation. And thank you all for your comments, sharing that same sentiment. And we do have some questions, so I'm going to open up both Kim and Matt's phones, and we'll take our first question, and that is, actually it's more of a comment, but it's a very good one, so I'd like to have both of your feedbacks on this, if you would. The question is, federal and county COVID reporting is now a CLIA requirement. It's a law. I'm a CLIA inspector. We continue to see smaller facilities who are not aware of this. In many states, this needs to be done within 24 hours of testing. This must be done for positive and negative results. Any comments on that, Kim?
So this is the comment versus the question, right? Yeah, that's a great point. Thank you for sharing that. I mean.
And Matt, if you have anything, go ahead.
So it's very hard when I think about the tanglement of agencies that we have in the U.S. and I think about you know, clear communication being key to getting something difficult done. We've given so many tangential groups the ability to ask for things from people that we have people ignoring things that are really important, thinking that something they've been asked for by somebody else is more important. And so if you asked me, how do we fix this? I'd say, we really do need a single way to transmit information back and forth that's shared, and that means somebody's going to have to give something up, and somebody, you know, might not get that data field that they really thought they needed in order to get things done electronically. Kim laid out a very good example, and we see this with our customers who are trying to meet state and federal reporting requirements. Some of them can be done with an interface. Some of them, just by virtue of what's being asked for, have to be done with a spreadsheet or some other manual process that requires, to your points, whoever asked the question or made the comment, that the reality is every day or every 24 hours, you're supposed to report these things. If people have 12 things to do, the manual ones that are at the end of the list are probably going to get dropped. And so just a general theme for me watching what's happened with the pandemic and who asked for what is, we should be able to get together and come up with an electronic interface that we all agree sends the right information and then send it, because I think that's a perfect example of something that probably half the people who are new to the CLIA regulations because they're doing COVID testing have no idea that they've been asked for it, and certainly are frantically trying to comply with all the other requests for reporting that they have. So I guess I'd summarize that with we have many customers who are feeling that same pain and angst, I guess.
Thank you both for that. We do have some questions about product solutions for this, but since this is a PACE accredited program, we'll have to ask our presenters. We'll get back with you with responses to that question after today's webinar. So the next question we have is, do we need an interface to get data sent to the State Department?
The answer typically is no, but it's a lot easier if you have one. And so we've seen, both sides of the spectrum. I think the skilled nursing facilities, when they were asked to report, found themselves in a tough place because they didn't have an automated way to do that or an interface to do it. Many other labs who have been reporting to, as Kim alluded to, certain test results to the state departments of health did have interfaces and could, make them more robust. So the answer is no, you don't have to have an interface. It can be done manually with a spreadsheet and a fax or some other crazy way to get it over there. But interfaces are, I think, helpful if you have a system that can use it. Kim, I'm happy to defer to any other judgment you have there.
I think you nailed it. You don't have to have it, but it certainly makes it easier, more efficient.
Okay, great, thank you. Google is in a notorious position right now. A lot of people are concerned with the company and its invasive use of private data to fuel their own advertising and business. Sorry, I didn't mean for that to be a political message here, but what specific incentives are being put in place to prevent companies to prevent them from abusing patient data? Still a very good question.
Yeah, that's a great question. Kim, I'll let you take a whack at it if you want to, or I'm happy to, but it is a great question, and it sort of goes back to that trust in what's going to happen to the data that gets shared. But Kim, if you want, you can share your thoughts, and I'll hop in.
It is a great question, and the statistics you shared earlier, with 17% of Americans trusting the government, it's a tall order. And, you know, I don't know if we have what we need aligned, but just as you and I talked about the other day, I think the answer is in making small incremental changes and then measuring those results and then making sure, demonstrating that the government is trustworthy for asking for more personal information access. So we saw South Korea's strong pandemic response, and that aligns with their 85% of the people trusting the steps their government was putting in place. But even with that number, they had that extra measure in there of deleting certain data after 14 days because long-term storage wasn't necessary. And so that step to acknowledge people's right to privacy is what helped earn that level of trust. And I think we need to move in that direction in our healthcare system.
Yeah, and I think when you talk about Google in general, they have access to just a tremendous amount of information. And it's clear that it's used to advertise, back to you, right? If you don't believe that, just talk around your phone for a while and then see what you start to see in ad pop-ups, right? So I share that sort of natural aversion to anybody having all of my information. And so I think that it is the crux of the question. I would look at de-identified data. There's a lot of things that we can do to show improvement in our system by simply using de-identified data in a better, more aggregated fashion. And so I hope we can start there, because I'm whoever asked the question, I'm not comfortable with Google being the source of interoperability for for all of our healthcare needs. I think it's a challenge for the country right now, especially, but I think we have to figure out a way to do it. I like the idea of overlays that pull information in a de-identified way. So rather than rely on Google to run this, they can provide the tool or build a tool, or some little IT entrepreneur could provide a tool that pulls information into a completely de-identified database, but it's useful information. So I think we can make strides, but I think there are a lot of folks who feel uncomfortable with entities who have access just to a tremendous amount of our information, even today without permission, just by virtue of using the platform.
In fact, you know what? Let me stick with South Korea questions, because a couple of them have just come in. So here we go. Testing was available much sooner in South Korea, and when available, was overwhelmed. How did South Korea handle testing availability and reporting so early in the pandemic? I'll give you the other question now, and we can come back to that first one and then second. South Korea was a mandated universal healthcare system, has a mandated universal healthcare system. Having such a system may also have been a factor in how the government could work with the pandemic response. So that may be an answer from one person to another person who asked that question, but what do you guys think? How did South Korea handle testing availability and reporting so early in the pandemic?
So I missed a note in my presentation. I was having so much fun that I forgot to mention, one thing that really kind of goes to the heart of the first question. How was South Korea so prepared? We talked about MERS and sort of their feeling that they were unprepared for that. But going back to the Indiana example, South Korea lives in very close proximity to what they would consider a threat of some sort on a daily basis. And so it would be like having Michigan mad at Indiana, and they happen to have chemical and biological weapons that they're willing to lob over the fence. So militarily, when I was in the service for 20 years, a lot of people stationed in South Korea, and back in the 90s, early 2000s, it was not uncommon to be walking around the base with your gas mask strapped to your leg, simply to be prepared in the event of some sort of an attack, because it was so close. That's not something that we in America would really typically think about. It's why we were so shocked in 9/11, right? So South Korea has a very different view of preparedness, I think, in general. And if you think about chemical and biological weapons being something you need to identify in the case of an attack, I think a more active mindset towards being ready for that. So I would put a couple of both the MERS lessons learned, as well as just the psychology of their proximity to a potential threat, as two reasons that they were willing and able to act much quicker maybe than we were. And the geography size also matters greatly. Kim?
Yeah, that sounds good, Matt.
No, how about the second? What was the second question? It was different, Rick. I felt like I answered the first one.
How did they handle testing availability and reporting so early in the pandemic?
They had to ramp up testing supplies,
yeah.
though, right, Kim? That was part of, they did have to ramp that up.
Yeah, and we, not to shine a negative light on us, but we fumbled it pretty bad. So it certainly helped them look better with us fumbling the start of testing ramp up.
And I think there is something to one governmental agency relative to insurance and distribution of things. In the case of nationalized health care, in that case, you've got one agency coordinating versus all the people that we have interested in our healthcare system.
Yeah.
Well, you just have to hope that we've all learned something from all of this. And by the way, speaking of learning something, we do have some more questions, but we have reached our scheduled stop time, and I know that some of you may have a hard stop on the hour. So if you need to get going, we thank you for coming. But for those of you who can stay with us, let's move to our next question. Just have a couple more. Do you have a list of points to consider as we set up our electronic medical record to prepare to be interoperable? A list of points to consider.
I read that question and thought that's something I would want, is a list of how do we get this organized and get this together. And I don't have a specific list, but I think it, like I said earlier, it aligns with the laboratory stewardship goals, where standardizing is kind of the key word there. Standardize your test names or test menus so that when you do go to put in your standardized codes, you don't have 5 different tests that are really the same test. You don't let, Dr. Smith order a test and Dr. Johnson order the same test, but they're under 2 different names because that's what those doctors have agreed to. That kind of is a step in that direction. We put in our LOINC codes in our system years ago when I worked in the lab, and it was a huge undertaking. But had we had our test menu pared down and organized and not just made all these custom changes per doctor, it would have been a lot easier.
Okay, thank you. Now, this next one is a comment. It's a bit of a long one, so I'll go through this. Thanks, Laura. We set up an interface for sending and receiving COVID test requests and results with our public health department through a grant. The biggest hindrance to the project was the coding of race and ethnicity. That prolonged the project by 2 months. The data of race, ethnicity makes no sense to me to have these 2 categories. I'm so glad to have the electronic interface and learn so much about HL7 messaging. I wonder how a universal healthcare system would impact this. Do you have any comments on that? This would be a great time.
So I think if we look at, and I have not seen a recent look at this data, but I do think that COVID disproportionately impacted certain races and ethnicities, and I think being able to see that in data sets would be important to react to getting resources, to the right people in the right place. So I think I understand why they asked for that. I'm sorry that it took so long to interface it. That's a bummer. But I think there were differences to the way that the pandemic or the virus actually affected folks. So I think that was the reason that was asked for. I don't, like I said, I haven't looked at the aggregated data lately, but I know early on that was a large discussion point. So it's probably why it was asked for. I don't have anything else for that, Kim. Do you?
Well, I was just trying to think, on the comment about the universal healthcare system, are we moving that direction? Does all the standardization push toward that? Yeah, I don't know. I think we're a ways off, but there are certainly some efforts toward that.
So it's interesting if you think about, doesn't matter which side of the, spectrum you're on. We want, one national healthcare system, or we want, freedom of choice with, private plans. The reality is taxpayers fund about half of the healthcare spend in the U.S. today already. So as we continue to spend more and more money in healthcare, I believe we will migrate towards something that has a choice of a government-funded plan. I'm very familiar with Medicare Advantage plans because our medical group was taking full risk on them. I believe a Medicare Advantage plan for all ages, if you wanted to buy into it, I think we could get most of the entities in healthcare aligned behind that. The ones that would scream and holler probably most would be hospital systems because the reimbursement is significantly lower than commercial rates. But the reality is we have to do something. The system's too expensive. It doesn't provide the right access for average American workers at an affordable price. And so changes are coming. I'm not sure what, and everyone will scream that patients will die, because that's what we always do when we talk about changes in healthcare. Patients will die. And it is a complex problem, but it requires a thoughtful solution, one that looks at how do we align stakeholders so that we just don't wipe out a third of the healthcare businesses with the stroke of a pen. That won't work either. So I expect us to migrate towards something like Medicare Advantage, opening up to other constituencies at a lower age. The only thing that would be required to make that work would be adjustments in risk adjustment scores, or RAF scores. And I'm sure the payers have already done that math. I haven't seen it myself, but I'm sure it's been done on at least the back of a napkin while drinking beer with Rick Import. I probably shouldn't have said that. Sorry.
It's been way too long since we've been able to do that. That's right. Hey, Matt and Kim, you guys are fantastic presenters. I've had wonderful comments, which I will be happy to share with you later, on your presentations and the value of all the information you've shared. So thank you so much for that. Thank you so much to both of you, Matt and Kim. Wonderful presentation. What a great tag team you two are. Thank you.
Well, Kim built all the beautiful slides, so she gets all the credit. I just showed up and tried to keep everybody awake after lunch.
Yeah, you bring the jokes.
Which we appreciate as much as the presentation. Thank you.
Thanks, Kim.
Big thanks to all of you for joining us. We hope that you'll join us again, as I said. And in the meantime, we continue to appreciate everything that you do out there every day and the front lines, and hope that you remain safe and healthy, and join us again very soon. So thanks, everyone. Have a wonderful rest of your day. And thanks to you, Kim and Matt. Great job. Appreciate it. Take care, everyone. Have a great rest of your day. Bye-bye.